So to take off on what Alan said, basically when the final regulations came out, we were told to pound sand. So there is going to be no renal ACO. But I want to explain that, because although this is a busy slide, you got to understand the politics behind everything. You know, our colleagues in cardiology think they know everything, so they should have a carve-out. You know, their heart failure patients are the sickest. And then the oncologists who basically, you know, single-handedly buried the use of ESAs, and that spilled into us, are convinced that their patients are the sickest and they should have a carve-out because they've been so responsible in the past. And then on down the line. So CMMI, in my opinion, did what I would have expected them to do. Punted. Just take a chill pill, let's put this out there, and let's talk. The current programs that were approved are the Pioneer ACOs, the Bundle Payment System, Innovation Challenge, the Primary Care Initiatives, and the Partnerships for Patients. All lovely names, reasonable programs, but no renal ACO. Now the argument, and I forget who brought it up here, you know, can nephrologists have their own ACO? Yeah, but we have a unique relationship. For all of the reasons we know, we have an affiliation with a provider, whether it's DaVita, Fresenius, or somebody else. And that is something that we have an opportunity to leverage, unlike any of our colleagues in any other area. And we know what's happening to them. They know they don't have a partner. So cardiologists are signing up with hospitals. Oncologists are signing up. They have no partners. We nephrologists do. It's a natural relationship we established through the medical director agreements and has continued to evolve. We are in the sweetest spot that sweet could be. And we need to be sensitive to that issue. We know through the pilot projects, the ESRD beneficiary projects that we did in New York and in Southern California, that fragmentation exists, we can save money, and this is something that needs to happen. So we have all the data. But this is one issue. What do we know for sure? And why do I use this slide? Is because I know for sure you would never approach a woman with a dog that big. But basically, we need to be sure about what we know. We need to know how to use that information to our benefit. And that's what I want to spend some minutes on. Here is the information that we have gleaned from the studies that we've already done, and many of you participated in. If you look at the top causes for admissions of ESRD, we know them all, okay? And you can see that we can impact this and have impacted this so that half of these are avoidable and 30% readmission rate can be controlled. This is huge savings just by applying an integrated care model that we did in the demonstration project. This is enormous savings. What else do we know? We know more about the cost and the throughput of a dialysis patient than any other patient out there. You've seen this, and it's boring, but you can put money to it, where delaying the progression, preparing for dialysis, transition to dialysis, and managing hospitalizations, these percentages are the cost savings. We know this. We have data. It's just not a touchy-feely good kind of, you know, the cardiologists say ultrafiltration will save this much money. This is very well-established information. We actually know the touch points for care. And Alan and I were talking this morning about a CMS project that would be looking at an intermittent care site, right? We already know, you know, we all have to live with ER doctors. It's kind of like, hey, Bob, we're admitting your patient. Why are you admitting them? Because they meet criteria. I said, every damn one of my patients, the healthy ones who are working, meet criteria. I mean, well, I'm going to admit them anyhow because I don't want to take the legal responsibility. All of these bizarre nuances. So there was a proposal put forward this morning about a regional intermittent care area where instead of a patient going to the ER with fluid overload and getting admitted, they'd come to these halfway houses almost, where they'd get intermittent care, more cost-effective, and be sent on their way. That's just an example of everything we know that touches our patients that makes a difference. And I think, what the hell, I don't know how but from catheter reduction to DaVita RX to patient pathways to the EHR to village, all of these modalities exist. Nothing has to be reinvented. Certainly things need to be tweaked, but so we know who our patients are, we have hard data on them, and we have processes and programs that exist to care for this. Now, I participate in the renal care management program in the patient pathways, and we've recently initiated this program in our Detroit hospitals. And the administrators just step back and say, oh my gosh, why didn't we think of this sooner? And the answer is simple, because they're thinking about 1,000 things, right? So we have to lead in our own backyards. Nephrologists need to advocate for nephrology patients. But the integrated care processes are there.